Dear audience, let me present my progress report on preconceptional, gestational, and postpartum carbohydrate metabolic disorders. My name is Dorina Greff, a resident doctor at the Department of Obstetrics and Gynecology. My vision to increase fertility and complication-free pregnancy rate, and my mission to achieve my vision by novel prevention strategies and to improve carbohydrate metabolism. In the last 2 years, we worked on 2 projects about inositol administration in polycystic ovary syndrome and gestational diabetes mellitus. In the first meta-analysis, we investigated the safety and efficacy of inositol administration in PCOS. The global prevalence of PCOS is 5 to 20%. The main characteristics of the disorders are polycystic ovaries and ultrasound examination, hyperandrogenism, and irregular menstrual cycles. The pathogenesis of the disorder is not fully understood. However, insulin resistance has a crucial role in its pathogenesis, and it presents in 75% of lean and 95% of overweight women. Metformin is commonly utilized to reduce this insulin resistance. However, it has some gastrointestinal side effects such as nausea, diarrhea, and vomiting. That's why another medical option is needed, which can be inositol. According to Australian guidelines, inositol can currently be considered as a complementary therapy in PCOS, with emerging evidence on efficacy highlighting the need for further research. That's why our aim to examine the potential beneficial effect of inositol in the treatment of PCOS. Our clinical question was that are inositols efficient and safe in the treatment of PCOS? We investigated women with PCOS. The intervention was inositol, and we compared to placebo or metformin. Our primary outcome was the presence of ovulation and cycle lengths, and our secondary outcomes were BMI, pregnancy rate, carbohydrate metabolism, clinical and laboratory hyperandrogenism, and side effects. Our hypothesis was that inositols are non-inferior compared to metformin regarding the presence of ovulation and cycle lengths. The systematic search was conducted at the 20th of October, and at the end of the full text selection, we found 26 eligible articles. To have a regular menstrual cycle is the key to women's fertility. That's why our primary outcome is cycle normalization. In the first set of this forest plot, we found 2 eligible articles comparing inositol treatment to placebo, suggesting that in the inositol-treated group, patients has twice more likely to have a regular menstrual cycle compared to placebo. We also compared it to metformin, where we found non-inferiority. In the next few slides, I would like to summarize the results of studies comparing inositol treatment to placebo. I colored those rows where we found significant results, and the different colorization is meant to highlight the quality of evidence. We found 8 eligible articles regarding BMI, suggesting that mere inositol has a beneficial effect in weight loss. Regarding androgen profile, we found that total and free testosterone levels and androstenedione levels are significantly decreased by inositol supplementation, and inositols can significantly increase sexual hormone binding globulin levels. We also investigated the glycemic profile, where we found that glucose levels and area under the curve insulin levels were significantly decreased by inositols. Here I summarize the results of studies comparing inositol to metformin, where we found non-inferiority in almost all of the cases except 2. In case of SHBG, we found inositol better, and in case of Freeman-Galway score, we found metformin better. The strength of our study is that we not just compared to inositol treatment to placebo, but also to the gold standard treatment metformin. We investigated plenty of outcomes, and we also investigated different inositol steroisomers. The limitation are the small number of studies with small sample sizes, the variable follow-up time, and the different RCTs administered different dosages of inositols. Implication for practice would be that inositols are effective therapeutic approach in PCOS, and they might be considered as a non-inferior treatment compared to metformin. Implication for research would be that further RCTs are needed with bigger sample size to assess the effect on pregnancy rate more accurately, and the possible additive effect of inositols and metformin co-administration should be examined. With this figure, I would like to summarize the central role of insulin resistance in the pathomechanism of PCOS. And based on our meta-analysis, the following factors can be influenced by inositol supplementation. So it can reduce BMI, it can reduce insulin levels, increase SHBG levels, decrease total free testosterone levels, and it may improve ovarian function too. So we can conclude that inositol treatment has beneficial effect on several parameters of PCOS, and in the most relevant outcome measures, inositol showed non-inferiority to metformin. This suggests that inositol is a promising alternative treatment in PCOS, especially in patients showing several side effects from metformin. Our first manuscript was accepted in January at Reproductive Biology and Endocrinology. Second meta-analysis, we investigated the myoinositol's effects, preventive effect in gestational diabetes mellitus. GDM affects 7% of pregnancies globally, and it can cause several maternal and offspring complications, both in short and long term. In short term, it can cause macrosomia, jaundice, hypoglycemia, and in long term, mother who suffers from GDM have a tenfold higher risk for developing type 2 diabetes mellitus and has a twofold higher risk for cardiovascular events. And despite of these facts, there's no medical treatment is generally prescribed for the prevention of GDM. And as I mentioned earlier, inositols are great insulin sensitizers. That's why our aim was to investigate the preventive effect of inositols in the development of GDM. Our clinical question was that can inositol treatment prevent the development of GDM in pregnant women? We investigated inositol administration compared to placebo or no intervention at all in pregnant women, and our primary outcome was the GDM diagnosis by the time of oral glucose tolerance test, and the secondary outcomes were need for insulin treatment, OGTT, maternal and fetal complications listed on the slide. Our hypothesis was that inositols can decrease the incidence of GDM compared to placebo or no intervention at all. The systematic search was conducted at the 5th of November at 2021, but we have updated the systematic search on 15th of December 2022. And at the end of the full text section, we found 7 eligible articles. Now let's turn to the results. The incidence of GDM is significantly lower in the inositol-treated group compared to placebo. And if GDM develops, the second most important question is the need for insulin treatment. And as you can see, the need for insulin treatment is significantly lower in the inositol-treated group compared to placebo. And inositol supplementation can also significantly reduce the risk of preterm birth too. So we can conclude that inositol treatment reduces the risk of GDM compared to placebo or no intervention at all in high-risk population. If GDM develops despite inositol treatment, it still reduces the risk of insulin need and preterm birth. And inositols can decrease the incidence of GDM. We have submitted our manuscript in April to Acta Obstetrica and Gynecology Scandinavica, and we are waiting for their answers. In the last year, I had 2 poster presentations, and I had also a TDK student who has already defended her thesis with the title of Treatment of Polycystic Ovarian Syndrome. And let me thank you for your kind attention with a quote from Bill Gates: "We all need people who give us feedback. That's how we improve." Thank you.
The efficacy of a treatment that is not vital, there is always a question. The nihil nocere, right? So you should investigate whether it causes any harm. So the side effects, and that is completely missing from your analysis. So I would phrase the question in a way that whether giving inositol prevents the development of diabetes without causing harm, or is it a drug which has no side effects?
Inositol belongs to vitamin B group, so it has no toxic effect. In the first meta-analysis, we also extracted data about the side effects, and we find really low data about the side effects because sometimes it can cause flatulence and no other data about it. And in these RCTs, we didn't find any data about the side effects because there were RCTs. So I think that probably they wouldn't get an ethical approval if inositol would have any toxic effects for the fetus.
And a very practical question. I used to live with 5 women, right? And 5 women.
Yes.
Of course, 3 of them were my daughters. The other one was my mom. But anyway, my first daughter had, during her second pregnancy, she had problems with high blood sugar levels. So next time, if she's going to expect another baby, would you recommend her to take this drug?
Yes,
Okay.
for sure.
Now I'm convinced.
There are several types of inositol, myo-inositol and glyco-inositol. They are in the literature. Some suggest when do you have to take myo-inositol and or in which combination.
There are some information about their combination, but it's not conclusive information because some articles suggest that in the ratio of 40:1, myo-inositol to decyroinositol is the best because in human body this ratio present in the most of the cases, but they have different effects. Meanwhile, myo-inositol effect on not just on insulin signaling pathway, but also it helps the aromatase activation, which results that androgen genes will convert into estrogens. So it will help to eliminate the symptoms of hyperandrogenism. Then decyroinositol is an aromatase inhibitor. So it will result that in short term, for example, for 8 weeks, it can help because it will improve the insulin resistance. However, after 8 or 12 weeks, there will be problem with decyroinositol administration because of the accumulation of androgens, because it blocks the conversion of androgens to estrogens.
The dosage of the inositol were in all publication what you use for the meta-analysis the same?
No, unfortunately, it was one of our biggest limitation. They, as we saw, probably the 2 times a day 2 grams of myo-inositol is the best. For example, for in the prevention of gestational diabetes mellitus. But some RCTs use just 2 grams, or some RCTs use the combination of myo-inositol and decyroinositol. And in this case, they used 1,100 milligram myo-inositol and 27.6 milligram decyroinositol.
It means that in the meta-analysis were the dosage and the combination of the inositol not the same, different. And
yes, that's why we had to do a lot of subgroups.
Thank you.
You showed us that around 60% of the patients are overweight, but nowadays we are meeting patients more often who are not overweight. If you start administration of the inositol, is there any differentiation in time, in recovery time of the ovaries, whether the patient is overweight or not?
Yes, probably inositol is better for lean patients, for in the case of lean PCOS patients. As we saw in the RCTs, probably 6 months so inositol should be administered for 6 months at least to see improvements in ovarian function.
In normal pregnancy care, oral glucose tolerance test is usually made on gestational week 24. In case of pregnancy, which has a therapy prior against PCOS, do you suggest the same method, or you should ask the patient to have this OGTT test earlier?
based on the Hungarian recommendations, I would suggest the early OGTT, but for a patient who suffered from PCOS, sometimes it's more beneficial if starts a diet at the first trimester and start to administer inositols too, and at the 16th week of gestation, just do not an oral glucose tolerance test, then fasting glucose level, and after that they should eat their regular breakfast, and after check postprandial 60 postprandial glucose levels at 60 minutes.
According to your first meta, those patients who were in the RCTs, were they metformin naive patients receiving the inositol as a first-line therapy, or they were pre-treated with metformin and then they got an inositol?
They didn't receive any pre-treatment.
Okay. And if you or your bestie were diagnosed with PCOS, which treatment would you choose?
If it was me, I said that inositol, because so it depends on the BMI too. Because if somebody start to administer metformin, and if this patient insulin levels are high, for example, but she's a lean PCOS woman, then metformin will cause a lot of side effects, a lot of problem, not just flatulence and noise and vomiting, but also her blood sugar levels will always be low and will be angry and frustrated. So, in case of lean PCOS, I would suggest that inositol is a better choice. If it's this patient is an obese patient, then it's a more tricky question. Probably both of them, but we have to do much more RCTs, for example, on this topic to give you a more precise answer.
I just have a minor comment instead of a question, or maybe a little question. You mentioned a few times that inositol is non-inferior to metformin. Mm-hmm. How did you come to that conclusion? What led you to be able to say that they are non-inferior? I didn't get that from the results, but maybe I missed it.
That was our hypothesis because of the BMI, of the different BMI of the patients. Because as I mentioned earlier, that for lean PCOS patients, inositol can be a great choice, but for really obese patients, inositol won't be enough probably. So that's why we try, because we pull the data, we try to state something neutral.
Okay, so basically you're saying that a non-significant difference is going to be a non-inferior result, if I understand well. So if you don't see an increase in efficacy if you compare metformin efficacy and inositol efficacy, if they are significantly not different, then you'd conclude that they are non-inferior.
Yes.
Okay. Then my minor comment comes now that's not the case, unfortunately. I don't want to go into how statistical hypothesis testing works right now, but it's not. Non-inferiority is a very strict way. It's a very strict term, and it's like statistical significance. It's very liberally used, and although it cannot be, so it's not. You cannot say that they are non-inferior. You say that we lack the evidence that they are different, which is not the same thing if you think about it. Okay. So I just like to advise you not to use that term that liberally. That's all.
I got one question that. You mentioned it in the beginning of the presentation. What's the real connection between insulin resistance and hyperandrogenism?
In hyperinsulinemia, the production of sex hormone binding globulin level in the liver is lower, and also hyperinsulinemia overstimulates ovarian cells for androgen production. And if the sexual hormone binding globulin levels are lower, then the free testosterone levels will be much higher, and this will result in hyperandrogenism.